Welcome back to the Deep Dive, the place where we cut through the densest, most challenging source material, your core medical textbooks, and turn those complex foundations into highly refined, memorable, and immediately applicable knowledge.
Today, we are undertaking one of the most crucial deep dives for any aspiring clinician, the foundational principles of oncology. We've synthesized everything from the molecular underpinnings of cellular failure right through to the critical clinical emergencies and therapeutic strategies found in your Davidson's material.
Exactly. Our mission today is to give you the essential shortcut. We want to bypass those hours of exhaustive reading and give you the necessary mental anchors to make sure this life-saving and exam-critical information is locked in.
Yeah, and we'll be using a couple of key concepts to do that.
Right. We're talking about things like the 10 commandments of malignancy, which describes how a cell goes rogue, and the cellular fitness meter, which, dictates how we treat the actual patient.
It's just so vital we anchor this knowledge because the global impact of cancer it's staggering.
Well,
We're not talking about a niche disease here. This is a public health crisis on a massive scale.
just give us the numbers.
Okay, think about this. Back in 2018, there were 17 million new cancer cases recorded worldwide.
And that's a number that only moves in one direction.
Precisely. That statistic is projected to skyrocket to 26 million new cases annually by 2030. And what makes this so challenging clinically is that nearly 70% of the deaths in 2018 occurred in low and middle-income countries.
Where basic diagnostic tools and fundamental treatments are often just not there.
Exactly. They're completely inaccessible. It just underscores the global inequality that's inherent in cancer care.
So before we even get into the molecular weeds, we have to talk about prevention. I mean, understanding the causes is where the biggest victories are won, right?
Absolutely. The foundational anchor for cancer etiology is that so many of these causes are entirely preventable. We have to remember the big three environmental contributors.
Okay, what's number one?
Number one is tobacco smoking. It remains the single largest preventable cause, accounting for over 20% of all global cancer deaths. When you look at lung cancer specifically, smoking causes 80% of cases in men and over 50% in women. It's just huge.
So roughly 1 in 5 cancer deaths worldwide is tied directly to smoking. That's a powerful motivator for public health. What's the next massive category?
That would be diet and alcohol. Together, they're responsible for an estimated 30% of cancers, including a huge portion of gastric, colorectal, esophageal, breast, and liver cancers.
And the message there is simple, even if it's hard to implement.
It is. Simple lifestyle shifts, reducing processed meats, limiting alcohol, increasing fiber, staying active. These offer a monumental preventative impact that far outweighs any single drug we could ever invent.
And the third one, which I think is often overlooked, at least in high-income nations, is the role of infection.
Yes. Infections contribute a significant 15% of cancers globally. And that percentage is even higher, closer to 25% in regions with strained public health resources. We're talking about cancers of the cervix, stomach, liver.
And the success story here is the HPV vaccine.
The human papillomavirus vaccine. Yes, it's an incredible public health victory. The widespread deployment of these vaccination programs proactively addresses a huge chunk of that global cancer burden. It's prevention in action.
That really sets the scale. We're dealing with a disease defined by statistics, preventable causes, and, well, global inequality. But now, let's pivot hard. We're zooming down to the microscopic level to explore that fundamental biological failure, the point at which a single, normal cell becomes a malignant machine. Okay, let's unpack this core concept, which we're calling the 10 commandments of malignancy. The idea is that if a normal, well-behaved cell is going to transform into this malignant, immortal, unchecked terror, it has to systematically acquire 10 fundamental capabilities.
And that framing is essential. Cancer isn't one single event. It's a process we call multi-step carcinogenesis. It's a series of successive clonal expansions, where each step is driven by the cell acquiring some new molecular aberration that gives it a selective advantage.
A survival advantage.
Exactly. These hallmarks are that survival advantage. So let's start with the first half, focusing on the core machinery of the cell itself. How it learns to proliferate endlessly, and crucially, how it learns to ignore death signals.
Where do we start?
We have to start with the enabler, the most foundational prerequisite. Hallmark number 1, genome instability and mutation. The cell's genetic code is under constant threat, from internal and external stressors. Normally, we have these incredible DNA maintenance and repair systems.
So what does the cancer cell do differently?
The cancer cell deliberately compromises those systems. It's like throwing sand in the gears of the quality control department.
Hmm.
This compromise, whether it's a point mutation, a big deletion, or even an epigenetic change, it just accelerates the accumulation of errors.
So that instability is the engine.
It is. It's the prerequisite for acquiring all the other 9 hallmarks. If the blueprint itself is highly compromised, the entire system is just destined for catastrophic failure.
Which leads us directly to the most critical failure in self-preservation. Hallmark number 2, resisting cell death. A normal cell, when it detects severe damage, should just commit ritual suicide.
And that suicide is called apoptosis, or programmed cell death. It's a clean, efficient disassembly. The cell just breaks down into these neat little packages that surrounding immune cells can clean up without causing any inflammation.
But cancer cells become masters at ignoring the signals to do that.
They do. And the single most non-negotiable anchor you need to remember here regarding the failure of apoptosis is the TP53 tumor suppressor gene.
This is the big one.
You absolutely must understand that TP53 is the guardian of the genome. It's the master switch. When P53 detects too much genomic damage, its first job is to pause the cell cycle to allow for repair. If repair is impossible, P53 throws a switch and initiates apoptosis.
And the staggering statistic here is how often the guardian fails.
Over half of all human cancers show a disruption, a mutation, in the TP53 gene. When the guardian is asleep at the wheel, the cell just ignores all those damage signals from chemo or UV radiation and simply continues to divide, accumulating more and more mutations.
You also mentioned it's important to differentiate apoptosis from necrosis.
Yes, that's a key point. Necrosis is messy, premature cell death from an external injury. A necrotic cell just bursts, releasing all its inflammatory contents into the microenvironment. And this inflammation actually helps the cancer. It recruits immune cells and promotes blood vessel growth.
That's a fascinating insight. So the body's attempt to clean up a dead area actually lays the groundwork for the tumor's growth. Okay, moving to hallmark number 3. Sustaining proliferative signaling. Normal cells are social. They need an external invitation to divide.
Right. Cancer cells become antisocial. They achieve independence by constantly providing themselves with the go signal. One major mechanism is what we call autocrine stimulation.
They make their own growth factors.
They make their own growth factors, like TGF-alpha, and they simultaneously express the receptors for them. It creates this continuous self-driving positive feedback loop.
Or if they don't make their own, they just misuse the existing receptors.
Exactly. They either overexpress the receptors or the receptors themselves become permanently activated, even without the growth factor present. Think of it like a faulty doorbell that is constantly ringing the divide signal.
And what are the key examples there?
The classic ones are the epidermal growth factor receptor, EGFR, in lung and GI tumors, and the ER2 receptor in breast cancer. Activating these permanently just drives uncontrolled division.
Okay, hallmark number 4, evading growth suppressors. If proliferative signaling is the accelerator, these are the brakes.
That's the perfect analogy. The cell cycle G1S, G2M is highly regulated by checkpoints. The transition from G1 to S is the big one, the restriction point. Once you pass it, you are committed to division.
And the traffic cops that enforce this pause.
They're tumor suppressor proteins, most notably the retinoblastoma gene product, PRB. PRB works by inhibiting the cyclin CDK complexes that are supposed to push the cell forward.
So the mutation here disables the officer, letting the cell speed right through the red light.
Correct. When PRB is mutated or inactivated, that inhibitory brake is cut, and the cell just barrels past the restriction point into DNA synthesis without any quality control.
And finally, for this first half, number 5, enabling replicative immortality. Why doesn't the cell just get old and stop dividing like a normal cell?
This is all controlled by the telomeres, which are the protective caps on the ends of our chromosomes. In normal somatic cells, these telomeres get progressively shorter with each division. It's like a mitotic clock. Once they reach a critical length, the cell enters senescence and stops dividing.
And the cancer cell's solution is?
The cancer cell reactivates a fetal enzyme called telomerase. This enzyme adds DNA sequences back onto the telomeres, maintaining their length. By flipping on this telomerase immortality switch, the cell achieves limitless division capability. It truly becomes immortal.
So it's easy to just rattle off 5 terms, but let's pause and connect the dots here. The cell must first compromise its genome repair. That's hallmark 1. But that massive damage would normally kill it unless it simultaneously disables the TP53 Guardian and flips the telomerase switch. These three are fundamentally linked.
That's the critical link. It's a multi-stage conspiracy. If you only remember 3 foundational molecular concepts, those are the ones.
Okay, so let's make this a bit more fluid than a standard check-in. Just reflect on this for a second. We've covered how the cell gets the internal power to divide forever. If you are sitting there now and you couldn't instantly explain the difference between apoptosis and necrosis, or why activating telomerase is so fundamentally different from disabling PRB, you need to quickly rewind and reinforce those points. They are absolutely non-negotiable for understanding cancer pathogenesis. Now we move to the second half of the strategy, how this rogue cell interacts with and manipulates its external environment. Starting at number 6, inducing angiogenesis.
Right. No tumor mass can grow beyond about 1 millimeter cubed without establishing its own dedicated infrastructure.
A functional blood supply.
A functional blood supply. This requires the angiogenic switch to be flipped and remain locked in the on position. It needs oxygen, nutrients, waste removal, just like any normal organ.
How does it do that?
The tumor achieves this by shifting the balance heavily toward pro-angiogenic factors. The star player here is vascular endothelial growth factor, VEGS. The tumor secretes these signals, commanding the surrounding host vessels to sprout new capillaries towards it.
It gets help, right?
It does. What's often overlooked is that this process is assisted by recruited host cells, macrophages, neutrophils, which help maintain this leaky, messy, but absolutely essential tumor vasculature.
Hallmark 7 is where the terror spreads. Activating invasion to metastasis, this is the cellular jailbreak.
It's arguably the most complex and lethal hallmark of them all. The crucial first step is something called epithelial mesenchymal transition, or EMT. Epithelial cells, like those lining our organs, are normally tightly bound together.
So the cancer cell has to unglue itself.
Has to unglue itself from its neighbors. The primary adhesion molecule is E-cadherin. The cancer cell actively downregulates or inactivates E-cadherin.
And once it's free?
Once it's unglued, it can break through the basement membrane, enter a blood vessel, that's intravasation, survive in the circulation, stick to a vessel wall somewhere else, exit the vessel extravasation, and finally colonize the new site. The whole thing is a massive, complex cascade.
Okay, number 8, deregulating cellular energetics. This is the famous Warburg effect, and it's one of the most intellectually surprising strategies. Why does cancer favor an inefficient metabolic pathway?
This is what I like to call cancer's great sacrifice. Under normal oxygen-rich conditions, the most efficient path for energy is oxidative phosphorylation in the mitochondria. It yields a huge amount of ATP. Cancer cells, however, reprogram their metabolism to favor aerobic glycolysis, a path that is about 18 times less efficient.
It seems like a huge evolutionary blunder. What's the so what here? Why do it?
The so what is that the cancer cell is trading power for speed. It's trading ATP efficiency for biomass building. While glycolysis is inefficient for energy, the intermediates produced, those partially processed glucose molecules, are shunted directly into essential biosynthetic pathways.
So they provide the building blocks.
Exactly. The building blocks for all the new nucleosides, amino acids, and lipids needed for the incredibly rapid production of 2 new daughter cells. The cancer cell prioritizes building material for replication over energy for existence.
Hallmark 9, tumor-promoting inflammation. The immune system arrives to eradicate, but the tumor turns the tables.
Right. We now know that almost all tumors show significant immune cell infiltration, and this inflammatory response, which we historically viewed as an eradication attempt, actually promotes tumor progression. These recruited immune cells release bioactive molecules, growth factors, and most dangerously, reactive oxygen species, or ROS.
And why are those ROS so dangerous to the host?
Because they are actively mutagenic. They increase the genetic instability of the surrounding cancer cells, accelerating the accumulation of new mutations. It's a tragic feedback loop where the fire department arrives and ends up fueling the blaze.
Which gives the cancer cell the perfect cover for the final command, number 10, evading immune destruction.
The successful tumor develops cloaking mechanisms, and the most clinically relevant strategy today involves co-opting the immune checkpoints.
These checkpoints are our self-tolerance mechanisms, right? They're designed to stop the immune system from attacking our own healthy tissues.
Exactly. And cancer cells exploit this beautifully. They highly express a protein called programmed cell death ligand, PDL1, on their surface. When PDL1 binds to its counterpart, PD1, on a patrolling T cell, It delivers a powerful inhibitory stand-down signal.
It tells the T cell to back off.
It effectively suppresses the T cell, allowing the cancer cell to hide in plain sight. And understanding this mechanism is what unlocked the entire modern era of immunotherapy.
That is the complete molecular strategy. It's an accumulation of 10 successive interwoven biological triumphs over host defenses.
We've moved from the blueprint failure to the final act of evasion. And now that we grasp the failure on a molecular level, we have to transition to the clinic and see how these failures manifest in a live patient, what we're calling the clinical canvas.
Okay, segment 2. This is all about translating the molecular disaster into actionable clinical steps. For medical students just starting their rotations, what are the high-yield things they must look for during a physical exam that might signal cancer or metastasis?
The clinical examination is always the starting point. You have to be systemic. So beyond general signs like fatigue and cachexia, that wasting syndrome, you must zero in on specific physical indicators of spread.
Like lymph nodes.
Definitely. Look for unexplained persistent or hard lymphadenopathy, especially cervical nodes, and most especially supraclavicular, which can signal thoracic or abdominal pathology, and of course, axillary and inguinal nodes.
What about findings in the lungs or the abdomen?
In the periphery, look for clubbing of the fingers, which is strongly associated with lung cancer. On abdominal examination, look for signs of liver enlargement or ascites, that's fluid in the peritoneal cavity, often linked to ovarian carcinoma.
And we can't forget the high-risk, life-threatening neurological signs.
Never. Always be alert for subtle, focal neurological signs, new sensory deficits, or personality changes that might suggest brain metastases. This meticulous approach feeds directly into our 3 pillars of assessment.
Let's define those 3 pillars again. Extent, staging, type, pathology, and fitness, ECOG. Determining the extent is done via the universal language of oncology, the TNM classification.
TNM tumor nodes metastasis is absolutely crucial because it dictates the entire management intent. T describes the primary tumor size or invasion, N describes the regional lymph nodes, and M describes distant metastases.
Why is this system so indispensable for management teams?
Because it immediately stratifies the patient. Are they early stage, meaning localized and potentially curable with surgery? Are they locally advanced, requiring a combination of therapies? Or are they metastatic, which is M1? And if they're M1, the goal changes completely. The goal immediately shifts from curative intent to palliative control, managing the disease, maximizing quality of life, prolonging survival. That single distinction, M0 versus M1, is one of the biggest clinical decisions we make.
And imaging helps us make that decision. We rely on CT and MRI, but how does the PT-CT fit in?
A PT-CT is so powerful because it visualizes the metabolic activity of the tumor cells. It's invaluable for assessing distant metastases when we're planning a radical curative therapy to make sure we haven't missed some small, distant focus.
But there's an important caveat, right? It's not a perfect test.
Correct. You cannot assume a clean scan means no disease. Not all tumors are PT-avid. And more critically, a PT-CT can sometimes lack the resolution to detect very small malignant lymph nodes, so you need careful interpretation alongside clinical suspicion.
Okay, moving to the second pillar. Establishing the type of cancer. This means you need tissue.
The diagnosis is almost always histology-based. We need a biopsy taken via endoscopy, guided by imaging, sometimes just cytology. As they say, the tissue is the issue.
And that pathology report is now less about description and more about providing a molecular roadmap for treatment.
This is the whole shift to personalized oncology. Pathologists use immunohistochemistry, or IHC, to stain for receptor status. For example, knowing the estrogen receptor and progesterone receptor status in breast cancer dictates whether you use hormonal therapy.
And then there's the most cutting-edge part, molecular profiling.
Right. Molecular profiling identifies the specific druggable pathways. In lung cancer, finding an activating EGFR mutation is a green light for specific inhibitors. Conversely, if we find a RAS mutation in colorectal cancer, that's a red light.
It predicts resistance.
It predicts resistance to EGFR-targeted therapies. This allows us to spare the patient an ineffective toxic treatment and move immediately to standard chemotherapy. Pathology now directs the drug choice.
That brings us to the third, most human, and arguably most important pillar, assessing fitness. And this is where we use our anchor, the cellular fitness meter. The ECOG performance status, PS scale, is our cellular fitness meter, running from 0 to 4. For first-year clinicians, understanding this scale is crucial because it's a primary determinant of whether a patient can tolerate aggressive therapy.
Let's detail the spectrum. PS0 is fully active, business as usual. PS1 means the patient is restricted only in strenuous physical activity. They can manage light work, they're ambulatory, but they get tired easily. This is still a good candidate for aggressive therapy.
PS2 is where the alarm bells start to sound a little louder, right?
Yes. PS2 means the patient is still ambulatory and capable of all self-care, but they're unable to work. They spend more than half of their waking hours up and about. They can still function, but they're struggling.
And PS3 and 4 are the critical states.
Yes. PS3 is severe, capable of only limited self-care, confined to bed or a chair more than 50% of waking hours. And PS4 is completely disabled, confined totally to bed or a chair.
Why does the status matter more than, say, a patient's chronological age?
Because fitness determines physiological reserve. An 80-year-old with a PS of 0 or 1 can still tolerate aggressive therapy, but a 60-year-old with multiple comorbidities and a PS of 3 likely cannot. When a patient is PS 3 or 4, aggressive therapy often causes more harm than good.
So the goal shifts purely to palliative symptom control.
Exactly. You avoid toxicity at all costs. That distinction between PS1 and PS3 is the difference between a curative approach and a palliative approach for many, many tumor types.
Okay, let's use a slightly more conversational check-in here to make sure this concept is grounded. Imagine a 75-year-old patient who used to play golf daily. Now they report they can only walk around their home and manage light errands, spending about 60% of their waking hours on their feet. Are they PS1 or PS2? And critically, how would the MDT's willingness to consider intensive chemotherapy change if they were PS2 versus if they were PS3? If you can't instantaneously place that patient or articulate the clinical consequences of that shift, take a moment to review the ECOG categories.
That's the whole point of this segment. Staging gives the map, pathology gives us the identity, and the ECOG fitness meter tells us if the patient can actually survive the journey.
We're moving now to the highest stress environment in oncology: crisis management. These are the oncological emergencies, life-threatening conditions that often bring cancer patients into the hospital acutely. They demand rapid recognition and mandatory immediate action. We'll cover 5 critical ones.
Starting with the most feared neurological complication, malignant spinal cord compression, MSCC. This affects about 5% of cancer patients, typically those with cancers known to metastasize to bone myeloma, breast, prostate, lung.
What's the progressive presentation that a student needs to recognize instantly?
The clinical course is always progressive. It usually starts with back pain, and it's a specific kind of pain, rapidly worsening, and critically, it is exacerbated by lying flat, coughing, or straining. That is a huge red flag.
And that progresses too.
It progresses to sensory changes, numbness or tingling, followed by objective motor weakness like leg weakness.
And the final, irreversible sign:
Sphincter disturbance, usually beginning with urinary retention. Once that is established, neurological recovery is often poor. This is a time-critical diagnosis.
So the mandatory management protocol.
Suspect MSCC ordered an urgent MRI scan of the whole spine. But while you're waiting for that, you deliver immediate, high-dose glucocorticoids. Dexamethasone 16 milligram IV stat. This must never be delayed by imaging. It reduces the edema around the cord.
Okay, our thoracic emergency is the superior vena cava obstruction, SVCO, typically caused by lung cancer or mediastinal lymphoma.
The clinical signs are dramatic and highly suggestive. Patients present with severe breathlessness, facial and arm edema, and visibly distended neck and arm veins.
There's also a specific headache, right?
Yes, a headache that is aggravated by bending forwards. It's due to the rapid increase in cerebral edema from the lack of venous drainage.
And management.
Diagnosis is confirmed by a CT scan of the thorax. In symptomatic patients, the immediate goal is relief, and that's often achieved rapidly via an SVC stent. That stent is the bridge to definitive anti-cancer treatment, like chemo or radiation.
Next, the systemic infectious crisis: neutropenic fever. This happens after cytotoxic chemo compromises the bone marrow.
Neutropenic fever is defined by 2 criteria: a fever of 38.3 degrees C or higher, combined with a critically low neutrophil count of less than 0.5. The mortality rate is high, primarily due to rapid sepsis.
What is the most crucial time-sensitive action, and why do students sometimes get this wrong?
The crucial point is speed. Students often prioritize the workup getting cultures, ordering an X-ray, and while the workup must be done, it must not delay the antibiotics.
It's antibiotics first.
The absolute mandate is immediate high-dose broad-spectrum IV antibiotics, ideally within 60 minutes of admission. We treat empirically. The 1-hour clock starts as soon as that temperature is taken.
Let's discuss the common metabolic emergency, hypercalcemia of malignancy, HCM, affecting up to 20% of cancer patients.
The most common mechanism is the tumor's overproduction of PTHrP, or parathyroid hormone-related protein. It mimics PTH, causing massive bone resorption. Symptoms are often vague: stones, bones, groans, and psychic moans, drowsiness, delirium, constipation, dehydration.
The confusion and dehydration are the acute dangers. What's the immediate priority in treatment?
You have to address the dehydration first. The very first step is copious 5e 0.9% saline, literally 2 to 4 liters per day to restore hydration and flush the excess calcium out.
And the drug therapy to solve the underlying problem.
Concurrently, you administer 5e bisphosphonates like zoledronic acid. These powerfully inhibit the bone-resorbing osteoclasts.
Okay, finally, the unique crisis of the new era, immune-related adverse events, IRAs.
These are specific to checkpoint inhibitor immunotherapy. When we take the immune system's brakes off, the resulting overactivation can cause inflammation in healthy tissues. We see colitis, pneumonitis, and endocrinopathies.
So the immune system, now unleashed against the tumor, starts attacking the host. What's the countermeasure?
The management is focused on dampening that runaway immune response using high-dose steroids. If endocrine organs are involved, like the pituitary or thyroid, hormone replacement must be initiated, and that's often permanent.
That segment required fast thinking, and that's intentional. Let's just reflect. A patient with a known primary cancer, now presenting with back pain and leg weakness, requires urgent care. If they develop sudden onset urinary retention, what single critical drug must you ensure is administered immediately while waiting for the MRI? The answer is high-dose dexamethasone. Understanding that hierarchy of urgency: steroids before imaging, antibiotics before cultures, is the non-negotiable takeaway here.
Timely recognition of these 5 scenarios is what separates a good clinician from a great one. Delay can lead to irreversible neurological damage, respiratory collapse, or septic shock. Now we transition from crisis to strategy, the treatment arsenal. We must first clearly delineate the goals of therapy before we even select a weapon.
What are the 4 main treatment intents that guide the multidisciplinary team?
We have curative intent, which is aiming for complete eradication, usually involving surgery. Then there's adjuvant therapy, which is systemic treatment given after the primary curative treatment to eradicate any residual micrometastatic disease.
And its strategic cousin, neoadjuvant therapy.
Neoadjuvant therapy is given before the primary treatment, usually surgery. And the benefit is twofold. First, it can shrink or downstage the tumor, making surgery easier. Second, observing the response on the surgical specimen helps guide post-operative management.
And the 4th is palliative.
Right. Palliative intent is for metastatic disease. The goal is controlling the cancer, relieving symptoms, and maximizing the quantity and quality of life.
Let's start with the oldest strategy, the nonspecific hammer, cytotoxic chemotherapy. This relies on the simple principle that cancer cells divide faster than normal cells.
Exactly. And the reason for all the systemic side effects, nausea, hair loss, myelosuppression, is precisely because these agents lack specificity. They attack all rapidly dividing cells, like bone marrow, gut epithelium, and hair follicles.
How do we classify them?
Usually by where they hit the cell cycle or DNA. First, you have the alkylating agents, like cyclophosphamide. These form covalent crosslinks in the DNA, preventing it from replicating.
Then those that starve the cell of building blocks.
Those are the antimetabolites. Think of them as molecular decoys. Methotrexate, for example, blocks the synthesis of the precursors needed for DNA. 5-fluorouracil does something similar. They just starve the proliferating cell of ingredients.
And the final classic class, which attacks the cell's physical structure.
The mitotic inhibitors. These target the microtubules, which are the cell's scaffolding required for division. The vinca alkaloids block their assembly. The taxanes stabilize them and prevent their disassembly. Either way, the cell gets stuck in mitosis and can't divide.
Given the near-universal side effect of myelosuppression, supportive care is vital.
It is essential. To mitigate the risk of infection from neutropenia, we actively use GCSF, or granulocyte colony stimulating factor. This growth factor accelerates the repopulation of myeloid precursor cells, reducing the depth and duration of that neutropenia.
Okay, shifting from the hammer to the precision missile. Targeted therapies. The prerequisite here is molecular testing to find a druggable target.
Right, and we can split these into 2 logical classes. You have the monoclonal antibodies, the mAb drugs like trastuzumab. These are large proteins that target extracellular proteins on the cell surface.
And the small molecules.
These are the small molecule inhibitors, the ICIB drugs like cafitinib. Because they're small, they can get inside the cell and target intracellular processes, usually the tyrosine kinases.
This precision is what makes that molecular testing so necessary, especially when we talk about resistance.
The example of colorectal cancer is perfect. We might want to use the EGFR inhibitor, cetuximab, but if the patient's tumor has a RAS mutation, the treatment will fail
Why is that?
because RAS is downstream of EGFR. If RAS is mutated and permanently on, then blocking the upstream EGFR receptor is futile. The signal is already active. Testing for RAS mutations before giving cetuximab is non-negotiable.
Okay, moving to the newest treatment frontier, immunotherapy, which we described as unleashing the T cell. This is all about the checkpoint inhibitors. We've established that tumors hide by engaging the PD-1-PD-L1 interaction to suppress T cells. How do the drugs reverse this?
They're designed to physically block that inhibitory interaction. By giving an antibody that binds to either PD-1 on the T cell or PD-L1 on the tumor cell, we effectively cut the communication line.
The T cell loses its stand-down signal.
Exactly. It becomes activated again and resumes its programmed function of attacking the malignant cell. The clinical impact of this has been truly transformative, especially in diseases like metastatic melanoma.
Finally, let's discuss localized therapies, specifically radiotherapy. How does radiation physically kill the cancer cell?
Radiotherapy delivers high-energy radiation that kills cancer cells primarily by damaging their DNA. This is either direct damage to the DNA strands or, more commonly, indirect damage via the creation of highly reactive free radicals from water inside the cell.
And the core concept that dictates the delivery schedule is fractionation. Why is giving radiation in small daily doses better than one big dose?
Fractionation is key. We exploit the physiological difference between normal and tumor tissues. The small daily dose allows normal surrounding tissues, which have intact DNA repair systems, to recover between treatments.
Whereas the malignant cells, with their compromised repair systems, can't recover.
Precisely. They accumulate lethal damage over the course of the treatment.
Before we move on, we have to address the long-term cost of cure. Late toxicities. This conversation is essential for every young patient.
It's non-negotiable. As we cure more patients, we have to manage the long shadow of treatment. Radiotherapy can cause late damage like pulmonary fibrosis or cardiotoxicity. Chemo can cause heart failure, neurotoxicity.
And even a secondary malignancy.
Yes. Certain agents carry a small but real risk of causing a secondary acute leukemia years down the line. But the most widely impacting late toxicity, especially for young patients, is premature gonadal failure and infertility.
And this is why the fertility discussion must happen before the first dose.
Exactly. It informs the decision to pursue sperm storage for men or embryo or egg banking for young women. Failing to have this discussion before initiating sterilizing therapy is a significant failure in patient care.
Let's now apply these foundational principles to 3 key high-incidence diseases, starting with breast cancer.
Breast cancer remains the leading cause of cancer death among women globally. The pathogenesis is a mess of genetics. 5 to 10% are hereditary, involving genes like BRCA1 and BRCA2, and a strong hormonal influence.
And the management of breast cancer is really the poster child for personalized medicine today, because everything depends on molecular subtyping.
Every single treatment decision hinges on the histological assessment of 3 markers: estrogen receptor, ER status, progesterone receptor, PR status, and HER2 status.
So if the tumor is ER/PR positive,
That immediately dictates the use of hormonal therapy drugs like aromatase inhibitors. In the metastatic setting, these are often augmented by a targeted drug class, the CDK46 inhibitors, which block cell cycle progression.
and if the tumor is HER2 positive,
That dictates the use of the targeted therapy monoclonal antibody, trastuzumab. If the tumor is triple negative, lacking all 3 receptors, those patients typically receive aggressive cytotoxic chemotherapy and increasingly may be candidates for immunotherapy.
next, ovarian cancer, often presenting as the silent killer.
Yes, symptoms are vague until the disease is advanced. Ovarian cancer pathogenesis also has a strong link to BRCA1 and 2, but an interesting finding is that anything that suppresses ovulation like pregnancy or the oral contraceptive pill appears to be protective.
Once confirmed, what's the anchor for management?
Maximally effective surgical debulking is the first mandatory step. This is followed by cytotoxic chemotherapy, typically a platinum-based combination like carboplatin and paclitaxel.
And there's a precision maintenance therapy for those high-risk BRCA-mutated tumors.
Yes, that's the use of PRP inhibitors. These drugs exploit the underlying DNA repair deficit already present in BRCA-mutated cells, using a mechanism called synthetic lethality to kill the cancer cells while sparing normal cells.
And finally, cervical cancer, where the etiology is so clearly defined.
Right. Cervical cancer is strongly linked to high-risk human papillomavirus, or HPV, infection. This is a massive win for public health, as routine screening and vaccination have dramatically decreased incidence in developed nations.
How is it managed?
It's often clinically staged. Localized disease is highly curable with either surgery or primary radiotherapy. But if the tumor is locally advanced, it requires combined chemoradiation, where radiation is given with a radiosensitizing chemo agent like cisplatin. Our final and really vital topic is survivorship. This is about the long-term impact of living with, through, and beyond a cancer diagnosis.
We're curing more people than ever before, which means the focus has shifted. It's no longer just about the acute phase of treatment.
Exactly. Survivorship is now viewed as a continuum. You have the acute phase during treatment, the extended phase in the first few years after, when recurrence risk is highest, and the permanent phase long-term.
So what does this concept mandate for future clinicians?
It mandates a need for structured, holistic care that extends far beyond the end of primary treatment. Patients face decades of potential consequences, managing late toxicities, dealing with infertility, chronic pain, psychological distress. A comprehensive survivorship plan is now a required pillar of patient-centered cancer care.
This deep dive has taken us on quite a journey, from the molecular chaos of the Ten Commandments of malignancy, remembering how the TP53 guardian fails and the telomerase switch activates right through to the systemic manipulation of the host environment.
We cemented the clinical assessment framework by emphasizing the three pillars: staging, TNM, pathology, molecular drivers like EGF, RAS, and most importantly, the ECOG cellular fitness meter, which dictates management intent.
We also reviewed the mandatory time-critical protocols for oncological emergencies, ensuring we know when to grab the dexamethasone or the broad-spectrum antibiotics.
Then we organized the treatment arsenal, understanding the differences between the nonspecific hammer of chemo, the precision missile of targeted mAb and NEBA drugs, and the power of checkpoint immunotherapy.
All underpinned by the principles of fractionated radiotherapy and a firm awareness of those late toxicities like infertility and secondary malignancies.
So, to leave you with a final thought, we discussed that intriguing observation that cancer in older patients sometimes progresses more slowly, potentially because the body's natural mechanisms for restricting vascular growth become more effective with age.
And right now, we try to starve tumors using anti-angiogenic drugs, but they often come with significant systemic toxicity.
So what if? What if the aged host environment is naturally flipping a switch that limits that vascular supply? What if we could identify and leverage that exact molecular mechanism in younger patients, creating a less toxic long-term strategy?
So instead of just trying to kill the cancer,
Could focusing on enhancing the host's natural resistance to vascular invasion lead us toward a paradigm shift? Not just curing cancer, but achieving stable long-term control, allowing patients to live with cancer, managed more like a chronic disease.
that is the frontier where deep molecular knowledge truly transforms clinical practice. Use these anchors and checklists as you move into your clinical rotations. Thank you for taking this deep dive with us.